Thank you. It's a pleasure to have this opportunity to speak with you and give a little oversight. And is someone in the back of the room going to load my slides for me? Let's see. So I give this talk with some reservations because there are many experts here who see many more patients than I do. So in deference to people who are more expert than I'll do my best. And as you've heard from some of the presentations yesterday, we're having some very exciting things done by people around the world who have come together thanks to the Erdheim-Chester Foundation and all your hard work. Also, I'm going to borrow very blatantly from the consensus article that Dr. Diamond and several of us were involved with to show you some pictures and illustrate some of the high points of what ECD is all about. And I'd like this to be interactive, so during my presentation, if something isn't clear, please feel free to wave your hand and ask a question. I'd be happy to kind of make things a little more clear for you. Well, as you probably realize, this disease was first described in the 1930s, and I'm sure it's been around for hundreds of years, but nobody really paid attention to it and could really put it together in a way that was understandable until Dr. Erdheim-Chester described a few cases in 1930. And they were involved with the histology of the condition and the fact that patients had pulmonary disease and cardiac disease. And I don't think they had the full scope of what we know today, but at least that's where it began. And one of the really frustrating things about this disease is that when pathologists look at the biopsies, there's really not a great clinical or a histologic characteristic of those cells that tells you this is exactly Erdheim-Chester disease. In many diseases that we deal with, we can look at the cells and say that looks exactly like disease X. Or there are special stains, special reagents that the pathologists use to identify cells of certain origin. So they can say a cell is a Langerhans cell histiocyte because it stains with CD1A and CD207. And those are just characteristics of the cell that pick up a color, and the pathologists see that color and say that's what this kind of cell is. But for Erdheim-Chester disease, the cells are just kind of amorphous. They're fat-filled, big cells. We know they're histiocytes, but they don't have enough special characteristics to clearly identify them as this one disease. It kind of goes across a lot of other diseases too. So just looking at the biopsy can't give you the diagnosis. And you need clinical correlations. You need to look at the patient. You need to talk to the patient. You need to look at their x-rays. And all of those things are very important in finally coming to the diagnosis. Well, as you're aware, one of the great advances in understanding this disease was the discovery about 4 years ago of the mutation called BRAF. And I'm going to delve into this a little more deeply in a bit, but that's been a groundbreaking discovery because it's allowed us to begin to understand the biology of the disease, but more importantly, have the opportunity to have certain drugs which target this mutation and go very specifically to kill cells that have this mutation. And that's very exciting. It's exciting, but there's also a huge word of caution because the side effects of these drugs are very significant. So it's not easy to give a patient one of these BRAF inhibitors and expect them to just have good effects. There are lots of unfortunate bad side effects. So there are other therapies too, and besides the BRAF inhibitors, we're going to talk about some other drugs that work on the pathway where the BRAF mutation exists, and there are several layers of this pathway, and there are opportunities for using drugs at different parts of the pathway to be effective in treating patients. And we saw a really great example yesterday of where I think one of the patients in this room is receiving one of the newer drugs and has had a really great result. Many of the things that we're doing today wouldn't have happened without this international cooperation. So I think all the professionals, and I'm sure you as patients and family members too, are very grateful for what Kathy Brewer and her group has done to get the ECD Association going. And I've been involved with the Histiocyte Society for more than 25 years, and that again is a society that has focused on trying to make rare diseases less rare and less unknown and to get new protocols out there, new treatments and new discoveries. So like the Histiocyte Society, the ECD group has really helped a lot of things. Well, how do patients present? Well, one of the confusing things about this disease is they present like hundreds of other diseases. Many people feel tired. They have fevers. They are sweating at night. This is like many lymphoma patients, and one of the things we look at and ask about when a patient with big lymph nodes comes in. Since ECD can affect the eyes and make tumors behind the eyes, it's not surprising that people have trouble with their vision and pain in their eyes, and some have extraordinary proptosis, which means the eyes are bulging out from the sockets because of tumors behind the eye, behind the globe. Pulmonary disease can cause a lot of difficulties, and it's very sneaky. People will be active individuals and able to do athletic things, and finally discover that they're not running as well, they're not able to walk upstairs, they're coughing, they have difficulty breathing, especially when lying down. Bone pain is a fairly frequent symptom, but amazingly, some people can have the classic osteosclerosis of their leg bones but not have pain. So it just depends on what these cells of the disease are doing, as what kind of products they're making that get out in the body and cause pain. You have seen some of your friends, and perhaps you yourself are involved, have what we call xanthelasma, which are fat-like deposits that are underneath the skin. They can be on any place in the body, but are very typically underneath the eye or around the nose, or actually on the eye itself. And they're collections of these Erdheim-Chester cells, which are filled with lipids and fat. And because they collect so densely, they make a bulge, and they make kind of a yellowish orange collection of cells underneath the skin that causes this particular finding. If the pituitary gland is involved, which it very frequently is in these histiocytic diseases, the back part of the pituitary gland is responsible for regulating our thirst and urination. And if that back part, which we call the posterior pituitary, has damage to it from any kind of disease, then the cells that make the hormone that regulates our thirst and urination will stop working, and our thirst becomes extraordinary. People are drinking literally gallons of water a day. They're having to get up in the middle of the night to drink lots and lots of water. Other endocrine problems happen because the front part of the pituitary gland is damaged, and so the process that stimulates our male and female hormones is interfered with, and therefore you get these other problems, the breast development in males, decreased libido. When the back part of the brain is involved, the cerebellum, then patients are going to have problems with their balance, their speech, their handwriting, and even their thinking, because not only does the cerebellum control these movements, but it controls the way we process information. So this is an unfortunate problem that happens in some ECD patients. It's more frequent in my LCH patients, but it is kind of a common thread between these two diseases. And because we understand now that the cells that cause ECD are part of a group of cells called myeloid dendritic cells, it just depends on which little pathway of growth and development they go to become ECD versus LCH. And it's not surprising that some of the clinical manifestations are similar in the two diseases. When the front part of the brain is involved and you get tumors in the cerebrum, you can have problems with depression and inappropriate behavior also. So this is a graph from the paper that was written on the consensus findings, and it shows that central nervous system findings, which include not only depression and trouble with your balance and trouble with your thirst and urination, but all these central nervous system findings can happen in up to 50% of patients. Also, 50% will get bone pain. The collection of lipid deposits under the skin that I mentioned happen in nearly 30%. The bulging of the eyes, again, at about 30%. Diabetes insipidus in about 25% of patients. The classic radiographic findings that I'm going to show you in just a minute include a condition in the leg bones, in the femurs or in the tibia, in which there is fibrosis and infiltration of the bones. And when you look at a plain X-ray or a bone scan or a PET scan, you see that there's a increased density or increased lighting up, so to speak, of the isotopes in the femurs or the tibia, and that's called osteosclerosis. And it's such a classic characteristic of Erdheim-Chester that if you were to have a biopsy that you couldn't quite understand, but you saw this osteosclerosis, you would know that it is Erdheim-Chester. Dr. Colby, a pathologist from Mayo Clinic in Arizona, had a very nice talk yesterday in which he said the pathologists are really in trouble here because they don't have these specific characteristics of the cells, and the radiologists are the ones who really help us make the diagnosis. The other very, very characteristic finding of Erdheim-Chester disease is something called the hairy kidney, which happens in about 70% of patients. And I'll show you a picture a little bit later. There are some other conditions that can cause this, but I think that if you see the osteosclerosis of the leg bones, the hairy kidney, and you look at the biopsy, those three things together can give you a very, very high index of suspicion that the patient has Erdheim-Chester disease. For some strange reason, this disease likes to coat blood vessels. It forms a sheath around the aorta, just like it forms that rind around the kidney. And when you look at CT of the abdomen or PET scans, you can actually see a coating of the aorta in the abdomen or in the chest. And this is a very classic finding. Sometimes the disease affects the lungs and spreads out over the bronchi and the blood vessels and just makes these webs of fibrous tissue which close down the functional part of the lung, the nice, lovely little alveoli, as well as the bronchi and the blood vessels. Some patients can have pericardial thickening. That's the pericardium is the lining around the heart, which keeps fluid so our heart can beat smoothly, and that lining can take on this characteristic thickness and fibrosis that's found around the kidneys, and of course would be a very drastic problem if the heart were constricted by this fibrosis. Other areas of the body, what we call the retroperitoneum, behind the kidneys, can have fibrous thickening and also can have a diffuse fibrous sheath in the back of the abdomen. So this is a very classic PET scan on picture A, which shows the osteosclerosis or increased uptake in the femurs and in the tibia. And then in a bone scan on this panel B, similarly you find the same picture. So either of these modalities is very helpful. And in fact, a plain X-ray can show this osteosclerosis too. So that there are many ways that we can discover this, but these are some of the best. And actually the PET scan is a really, really good way to investigate patients because we can see how they look before we start therapy, and then within 2 to 3 months of being on therapy, we can see how effective it is, because the PET scan will show decreased uptake when the therapy is effective. Bone scans are a little less sensitive. They will remain abnormal for many, many months. So many of us like to use a PET scan to see that our patients are responding well to the therapy. Here's a compendium of very different radiographic pictures, including a CT that shows this hairy kidney aspect with a thickened rind around the kidney and little strands of fibrous tissue that make it look like hair. One of the most troubling parts of the renal involvement is that this sclerosis. We have a question?
Yes, sir.
Back to your PET scan.
Yeah.
We went down to, or for us it's down from Minnesota to, for my wife, for Barnes Jewish with Dr. Gabati. We ran PET scans for the first 6 months, and the insurance companies, how did they say it? She fulfilled her lifetime coupons for PET scans. How can we correct that? Because it's so important, if what you're saying, to follow this disease. How can we get this accomplished to allow patients such as my wife or the rest of these folks in here with ECD to correct this problem within the medical field as with insurance, to be able to allow this to happen instead of falling off the edge of the shelf without having a way to track something better?
Sure. The best way is to have a scientific article or a clinical article published in a journal showing how effective PET scans are in monitoring patients. I've published an article on Langerhans cell histiocytosis, reviewing 44 patients, showing how effective PET scans are for diagnosing and following. And we could use that article as a little bit of ammunition, but it would be even better if our colleagues here in the Erdheim-Chester world would publish a similar article showing how effective PET scans are in allowing us to monitor our patients. So I think we maybe have a little edge on the insurance companies, but it might not be good enough till we collectively put together an article on ECD specifically. But that's a chronic problem and very frustrating, I agree. So back to the kidney difficulties here. Well, besides damaging the kidney by encasing it in this rind, this fibrous tissue can then work its way down on the ureter. So the ureter is squeezed, you can't excrete urine, and a patient will need to have a ureterostomy, a tube put through the back into the kidneys to drain the urine that goes into a bag. Not a very pleasant thing. And I've known several patients who've had this, and unfortunately, once this fibrosis sets in for many months, it's difficult to reverse it. And although we might see an improvement in PET scans, that there's decreased activity, the actually fibrous tissue may stay there forever. So it's one of those things obviously we would want to catch very early so the ureteral fibrosis would not happen. Here's an example of the heart where a fibrous lump of the ECD tissue is impinging on the right atrium. The lung is diffusely involved in this patient with all this whiteness that's not supposed to be there, some whiteness here that is constricting the bronchi and causing this patient to have a lot of trouble with their breathing. Here are a couple examples of central nervous system involvement with the infiltration in the what we call the tentorium. It's kind of a layering between the bottom part, the cerebellum, which is in the back part of our brain, and the cerebrum, which is above. But this infiltration of the ECD tissue is coming into the cerebellum. This patient also has tumors behind his or her eyes, which are causing problems with their vision and causing their vision to be double. When the cerebellum is infiltrated in this way, down, back in the pons here in the cerebellum, this is the characteristic finding that will cause patients to have trouble with their balance, their speech, their handwriting, and their thinking. This is the pituitary gland. It's a little almond-shaped, coffee bean-shaped gland hidden kind of in the lower part of our brain. It's connected to the brain by a little element we call a stalk, S-T-A-L-K. And when that's thickened and too white like this, it means the disease is infiltrating. And this patient probably has diabetes insipidus because the back part of the pituitary doesn't look normal. Well, this is what a biopsy of an ECD patient would look like to the pathologist. It's just stained with the common stain we call hematoxylin and eosin. It just makes red and blue colors on the cells. And these very large histiocytes are full of lipid. The nucleus is kind of pushed off to the side and kind of small. And like I mentioned, there are many diseases that have cells that look like this. So this by itself doesn't tell us it's Erdheim-Chester disease, gives us a high index of suspicion. But you really have to put it together with a whole clinical and radiographic story. Why does Erdheim-Chester have so many different aspects to it? It's because the cells are making different products, and these products are inflammatory proteins, and in one aspect, these are proteins that are supposed to be helpful for our bodies, but when a disease like Erdheim-Chester or Langerhans cell histiocytosis gathers a bunch of these histiocytes together in one place, and they are turned on to make more of these proteins than they ought to because of the BRAF mutation, then you get a big outpouring of these proteins, and they're very harmful. And one of the most important proteins is interferon alpha. And this is a protein of the immune system that helps kill viruses, it helps kill tumor cells, but in this disease, it causes problem. It causes pain, fever, it damages the bone marrow, probably damages the lung and the kidney also, and that leads to a lot of the secondary problems that we know are associated with Erdheim-Chester. And then there's a little protein called interleukin-12, which increases interferon alpha production. So it's like a double whammy. The interferon alpha is turned on by one thing, it's turned on by another thing, and together these really creates a very bad environment for our bodies because these proteins are at such elevated levels they become very dangerous. Interleukin-1 is another protein that's elevated, and there have been some interesting papers from the French group showing how this interleukin-1 impacts the production of other proteins of the immune system. But fortunately, this is a nice target, and there's a drug called anakinra, which some of you may be on, and that anakinra is specifically targeted to stop this interleukin-1 production, and it really is quite effective. The macrophage colony protein 1, or MCP1, attracts histiocytes to a lesion, so the Erdheim-Chester cells are off kilter and they're making proteins that are out of balance, and this MCP1 attracts more histiocytes to the lesion, so it kind of amplifies the effect of the original cells. One of the important things that the physicians have done in trying to organize the way we think about these patients is to categorize patients so we can have them into little groups and understand how this group responds to drugs and that group responds to drugs. It's very confusing in ECD because a patient could have many, many different parts of the body affected. And I think it's helpful if we try to categorize patients into those with no symptoms and those that have mostly skin disease, or those that might have bone lesions with or without pain. So those are patients that don't have other organs involved. And then there are patients who are much more seriously affected when they have central nervous system, cardiac, retroperitoneal, orbit or craniofacial, the endocrine glands, including the pituitary, pulmonary, and those who have multi-system involvement. And so just trying to put patients in little groups so we can kind of understand how a group responds to a therapy versus kind of a diffuse, large accumulation of patients. I'd like to spend just a little bit time talking about the BRAF mutation. It's sort of confusing, and I think even some of us scientists and physicians are still confused by it. BRAF stands for BRAF activating factor. And this is a gene that is found in the middle of this pathway here that's important for cell signaling. So if a cell, this is the outside of the cell here, receives a signal from some protein that's supposed to be a growth factor or a hormone, that signal has to be transferred from the surface of the cell out here down to the nucleus here for the cell to respond. So how does that happen? There are incredible complex pathways of where the signal starts at the cell surface, it goes through a couple of proteins just below the cell surface, and then gets to a bunch of very interesting genes, which are what we used to call oncogenes. They're cancer-causing genes that were found in viruses, and then those genes were then found to be normal genes in the human genome and found to be mutated or abnormal in many cancers. And so when you get down to this RAS activating pathway, we see that there's a BRAF, and there's an A, and there's a C. And then the next thing that happens once these RAF proteins make their signal, they signal a protein called MEK, and then they signal a protein called ERK, and finally that ERK sends information down into the nucleus to get the DNA activated to make RNA, to make proteins, which either tell the cell to grow or stop growing or make a new hormone or make something that is supposed to control the way a normal cell works. But in a disease such as a cancer or Erdheim-Chester disease, when there's a mutation of the BRAF gene that's supposed to be an on-off switch, well, when it's mutated, it's always on. So this on signal keeps telling the cell, grow, 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 and therefore you accumulate all these cells in a tumor like the xanthelasma in the eyes, or the rind around the kidney, or the osteosclerosis in the bones. So this is great to know what genes are involved, because there are now drugs that target these specific areas, and they're drugs that will target the BRAF and the MEK and the ERK. But one of the very complex parts of this pathway is that if you block one of these proteins, the other proteins can take over. And so there's a kind of a backwards effect, that something that will feed back on the ERK protein from another direction can circumvent the block. So you think you block the BRAF gene, but the cell is too smart, and it goes around another pathway. So what we really think now is that finding drugs that work down here at the bottom of the pathway on the ERK and MEK part of the pathway will probably be most effective. Unfortunately, all of these drugs have side effects that are really unpleasant for some people, and not every patient can be on these drugs for long times. So although they may be a home run for some patients, they could be a really bad strikeout for others. Well, what are the treatment options? The clinical trials that are now ongoing nationally and internationally include vemurafenib, which is the anti-BRAF mutation drug. Tocilizumab is a drug which works against the cell growth factor called interleukin-6, and this is a very powerful monoclonal antibody that acts like a magnet and just soaks up the interleukin-6. And we saw some illustrations yesterday of very dramatic responses of patients to this. But like all of these drugs, they're not home runs for every patient. Some patients respond good to one, some patients respond good to another. So we have to kind of march down the possibilities to find the right drug for each patient. And it was just recently a very interesting study published using sirolimus, which is a drug which affects T cells. It is used in transplant patients to make the immune system quieter, so that the transplanted kidney or heart or lung or bone marrow can live more happily and not be destroyed by the normal immune system. Well, in ECD, it happens to somehow affect the pathways that cause the ECD cells to grow, and in combination with prednisone seems to work against the RAS type of genes and is an effective therapy for many patients. Interferon has been the standard of care for many years, and there's a new form of interferon called pegylated, and essentially packaging the interferon in a bunch of lipid molecules so you can inject that into the muscles of the patient, and it sits there and slowly gives the drug out over days and weeks. And that's a very nice way to do it, because it takes fewer injections rather than the regular interferon, which is 3 injections a week. Anakinra, as I mentioned, is an interleukin-1 drug. And then there are chemotherapy drugs such as cladribine, also known as 2-CDA, imatinib, also known as Gleevec, and infliximab, which is an anti-tumor necrosis drug. So there are many therapies now. I think this is encouraging for the community that we have choices, and our challenge as physicians and scientists is to choose the right drug for the patients, and more importantly is to develop clinical trials. And that's one of the topics for the discussion by the physicians, is how to develop clinical trials where we can put enough patients on to get a scientifically valid answer as to, is this good or is it not good? So I think I'll wrap up, and I'll be glad to answer any questions. So we have a question over here. Well, you usually need about 20 patients in a trial to get a 0.05 p-value.